Hello, and welcome to our second part on the neurophysiology of attention on attentional networks. Today we're going to be talking about the Posner theory of attentional networks, which includes three attentional network systems: an alerting system, an orienting system, and an executive control system. We'll also talk a little bit about self-control and integrative mind-body therapy and how it can be associated with improvements in attention. And then we'll also talk about issues like gender differences in attention, attention deficit hyperactivity disorder, and how drugs affect attention. But first we'll talk about the Posner theory of attentional networks, or Posner's attentional networks. It's often just called the attentional network theory, first proposed by Mike Posner and recently updated by Peterson and Posner in 2012. These three attentional systems include a subcortical system or an alerting system. This is our most primitive attention network. It's involved in our general level of arousal and alerting, providing warning or signals or danger signals that we need to pay attention. The posterior system, or the orienting system, is involved in the direction of our attention in space. This is based on sensory information, so this is how we allocate our attention to particular locations or objects. So as we try to fixate on a particular location, if we're expecting something there, so for example, if you're going to try to catch a ball where you might expect the ball to come from, you might direct your visual attention there. As you are watching a football game, you may direct your attention to a particular player, whoever has the ball, and so your ability to follow that to different locations is part of that attentional orienting system. The anterior system, which we now call the executive control network, is involved in our ability to sustain our attention to object or events, make selections based on abstract information, and to switch among tasks, and we'll talk about that as well. The subcortical system, or the alerting system, is again the most primitive. This is what sort of alerts us to the fact that there might be potential danger. So this is kind of where things like our startle response can come from, or our increased vigilance if we're in a stressful situation. So for example, if the sympathetic nervous system kicks in, the alerting system will kick in and we'll focus hard, we'll hear sounds more quickly. And you've all had this experience of walking in dark places, or the lights suddenly go out and your level of awareness goes up, and this happens automatically. So the alerting system is one that's really not under our cognitive control. It really happens automatically. We're going to talk for each of these networks about the kinds of tasks that are involved in each of these networks. So alerting tasks involve things like vigilance tasks. So in the laboratory we test this with the basic visuospatial vigilance task. They're usually fairly boring, where you sit and watch like letters pop up, and then rarely one will pop up that you're supposed to pay attention to. And they appear in various locations. The real-world analog of vigilance tasks are things like radar operators. They're sitting there waiting for something to happen. Very low-frequency events. So, for example, a fire control officer on a U.S. naval ship, for example, might be monitoring airspace in an area where there are no airplanes, so there's really nothing really happening. Similarly, you would think about, for example, a sonar operator on a submarine. We call that tonic alerting. So just basically paying attention to what's happening over long periods of time. Phasic alerting is done with cueing tasks. So usually you get some kind of warning. So a tone, in the laboratory, a tone or a visual signal will say, oh, something's coming up, pay attention, because you're going to need to do something here in a minute. We have these all the time in our environment, and the problem is oftentimes we can get confused by what cue it requires us to pay attention to what. So as we're driving our car, something beeps. What is that beep for? In emergency rooms and critical care units, things will beep all the time, and it tells us we're supposed to pay attention to something, but oftentimes we don't know exactly where to. So the subcortical or alerting system involves things like the locus coeruleus, which is activated following a warning signal. So you get a warning signal, the locus coeruleus will activate. Drugs blocking norepinephrine will decrease our alerting signal, while drugs that increase norepinephrine will increase our warning signal. So norepinephrine is definitely involved with this. That's why we believe this is primarily involved with the sympathetic nervous system, because the sympathetic nervous system involves increasing norepinephrine. through the HPA axis, as well as cortisol. Current evidence indicates that the right hemisphere is involved in sort of slower tonic alerting, so this paying attention to radar screens, etc., while the left hemisphere tends to be more involved in that rapid phasic alerting, so when a warning signal is sent out, it's primarily involved in the left hemisphere. One of the things that's important to note, and we'll talk a little bit about this here in a bit, is some recreational drugs increase norepinephrine levels and cause people to be quite paranoid. So their alerting level is quite high. And so what's happening is that norepinephrine increases, and so any sound, any movement, anything at all will cause people to be quite paranoid. And so that's something to keep in mind. So here's a look at the tracks involved in the alerting system. Again, subcortical brainstem, some innervation of the cerebellum, and then up here to this locus coeruleus cells here that then project up to cortex that tell us to alert to these systems. So while the alerting system is primarily located here in the subcortical areas, it projects to the cortex and gets the cortex involved in all of that. So it tells us to pay attention, and then all of the rest of the brain gets involved in monitoring and finding things in the environment. So the orienting system is focused on our ability to prioritize sensory information by selecting a location or a modality. So while the alerting system tells us we need to suddenly pay attention, the orienting system is much more flexible. It allows us to prioritize sensory information. Now, based on information from the alerting system, we might orient to a particular location. So if there's a sudden loud crashing noise, that's dangerous to us, and so we'll automatically orient to that location. So the sound acts as a warning, the alerting system activates, and then our visual system, or the orienting system, will orient us directly to where the source of that sound was. So this is tested in the laboratory using what is called the Posner cueing task, or the Posner cueing paradigm. And there's a bunch of variants of this. This is one that I've used in my laboratory, where participants fixate at the center of a screen, or before the trial starts there would just be a plus here. Then they get some sort of directional signal, and in this case this would be a valid trial, and a target then appears in one of these 4 locations. The participant's sole task is to press a key whenever this task appears. It doesn't have to be in the cued or non-cued location, just when that asterisk appears. Participants automatically orient based on this arrow cue. This is called an endogenous cueing paradigm. Exogenous cueing paradigm. And what they learn very quickly is the cue is predictive 80% of the time, which is an important part of this. And so they will automatically orient to that particular location, and based on the arrow cue. This would be an invalid trial, so they've oriented their attention to the same location we just showed you. Now they've got to find the target at a different location. Now there's some question as to what's happening at this point, but participants are much slower at finding a target in these conditions. And one of the things that's certain, we know they have their attention focused on the cued location, but what's happening at the other locations? Well, obviously part of it's that they have to take the time to switch from one location to the next. But there is also the belief, and certainly this is part of my view, is that these other areas are actually actively inhibited. That is, they're downgraded, and so it's harder to detect the target in those locations because we have actively ignored those areas, so it's a more active process. So we measure what's called the validity effect, where we take the invalid reaction times minus the valid reaction times. So slower to find the cue in the invalid cued conditions, faster to find them in the valid cued condition, and this measures the cost of having an invalid cue. There's evidence that those non-cued locations are actively inhibited, and we'll talk more about this in a bit, but women show larger validity effects. I found this in my research, and a number of investigators have found this in their research as well. So this is a consistent of finding that women show larger validity effects. What we don't know is why that is. There are a variety of potential explanations. It can certainly be that women aren't as fast as switching. We know men have faster reaction times, and we'll take a look at that data here in a moment. Men have faster reaction times. But it's also possible that women are actually better at actively ignoring what they're not supposed to be paying attention to, so they're ironically better at attention tasks, and as a result are slower to move to the alternative location because they have inhibited that location to a greater extent. So here's a look at the data from our paper. Men are on the left, women are on the right. These are from two different conditions with the upper and lower panel, or two different experiments, very similar. So the data is very consistent across the two. You can see reaction time is the measure plotted. Men are faster overall, consistent with lots of previous data. But what you can see is, if you look at the difference between the valid trials, which are the circles, and the invalid trials, which are the squares, there is a much greater difference between those trials for women than for men. The squares are control conditions where no cue is given. They're just a target appears somewhere. What you can see is for males, that warning cue, even if it's invalid, actually gives them a little bit more alerting. So there may be something in the alerting system that's going on here. So they're faster at invalid trials than control trials. Whereas for women, they weren't getting any benefit, and in fact, a bit of a cost from that invalid trial. So a little bit about how this has some potentially important applications. So the neuroanatomy of the orienting system, it's a more dorsal system, which includes the frontal eye fields and the interparietal sulcus. We think that breaking the focus of attention on an invalid trial involves the temporal parietal junction. We have seen recently that if you inject anticholinergic drugs into the parietal lobe, it has large effects on the ability of macaque monkeys to shift their attention. So you can see here the orange is the inferior parietal sulcus and the superior parietal lobule. And then in the blue we have the inferior parietal lobule and the temporal parietal junction. One of the things we have seen in recent evidence is that the temporal parietal junction has been associated with perspective taking. So if you think about the intentions of others and consequences to others, that is, take someone else's perspective, you see this same area, and back up here, there in blue, right here, you see this same area involved in switching from our perspective to someone else's perspective. That makes perfect sense because we are reorienting ourselves to a different perspective. And so it's pretty clear that this temporal parietal junction is involved in that breaking the focus of attention and switching to a different field of view. So that's the orienting system and the Posner cueing task. This has certainly important parts about how we pay attention to parts of our visual field and ignore others. So when we're talking about things like driving performance, pilot performance, all sorts of other applied tasks, this is a really important part of that. So this starts to become really important in human factors designs as well as other areas. The final part of Posner's control networks is the executive control network. This includes a frontoparietal network and a cinguloopercular network. So we'll talk about those, and then we'll finish up a little bit with some deficits in executive control. Again, first thing I want to talk about is how we measure the executive control. There's a number of ways in which this is tested. In the Posner cueing paradigm, Posner cueing tasks, including what's called the attentional network task, is included what's called the flanker task. And here, the simple task for participants is to indicate whether the central arrow is pointing to the left or to the right. These neutral trials, obviously there's no information, nothing that's conflicting with that or helping that. In the congruent trials, participants are much faster because the arrows are all pointing in the right direction. Whereas in the incongruent trials, they have to really actively work to ignore these flankers, that's why it's called the flanker task, and focus on the direction of the arrow. So the bulk of the information is pointing this way, whereas the information we're focused on is right here. So that makes it difficult when we have to try to ignore these other tasks. So that's the flanker task. The Wisconsin card sorting task is oftentimes used to test patients with head injuries, particularly any kind of closed head trauma. Basic idea is this: there are these 4 exemplar cards, and the patient's task, or the participant's task, is to sort this card based on one of the attributes. So it could potentially go on this pile if the rule is to sort based on shape. It could go in this pile if the rule is to sort based on color, and it could go into this pile based on sorting based on number of items on the card. So the person giving the test doesn't tell the person taking the test exactly what they're supposed to do, but place them on the appropriate pile, and then they simply say yes or no. So let's say they take this card here and place it on the first pile, and the participant and the investigator says no. So they get dialed another card, and let's just say it's this same card, and so then they place it here, and the investigator says yes. Well, that means the match is based on color. So then they'll start sorting based on color. At some point, the investigator will switch, and so they'll switch from color to shape. So now they'll place this card on this pile, and the investigator will say no. Well, what they now have to do is use that information, that feedback, to guide their future behavior. So they have a conflict, and they have to try to fix that error. So a person with perfectly normal executive functioning will now hypothesis test. So they'll try to place it here or here. Someone who does not have normal executive functioning, we'll talk about here in a minute, will make what are called perseverative errors. That is, they will consistently try to sort based on the old rule. They'll perseverate. And then finally, the Stroop task, something that all psychology students are familiar with, where you have color words, and you have to ignore the color of the word, the word itself, and focus on the color of the letters. So there is conflict there. So one of the issues with executive control is there's almost always some sort of conflict. So the frontoparietal network includes a lot of different areas, including the precuneus, the medial cingulate cortex, the dorsolateral prefrontal cortex, the dorsal frontal cortex, the inferior parietal sulcus, and inferior parietal lobule. Really, most of the action here is in the DLPFC and the DFC, so the dorsolateral prefrontal cortex and the dorsal frontal cortex. The precuneus is the sort of inside part of these parts of the frontal cortex, and then the medial cingulate cortex as well. The cingular opercular system involves primarily the dorsal anterior cingulate cortex, and so we'll talk a little bit more about that here in a bit. So this frontoparietal network is associated with starting and stopping a task, and moment-to-moment monitoring of tasks, and resolving conflicts and task switching. So the the frontoparietal network is primarily involved in not in maintaining the task, that is the other network, but in starting a task and then moment-to-moment monitoring a task, so resolving those conflicts, so things like the Stroop task, and then switching from one task to the other. The cingular opercular network is primarily the anterior cingulate, and its primary function is to maintain ongoing task performance, to sort of keep things going, and sort of maintaining attention on task, so keep people on task is really the primary involvement here. So one of the things that can happen is individuals who have particular brain damage, either due to stroke or other penetrating injury, or sometimes even just due to closed head trauma, they can often have damage to the dorsolateral prefrontal cortex. It seems to be particularly susceptible to head injury. These people often have executive function problems. In particular, DLPFC lesions result in those perseverative errors on the Wisconsin card sorting task I talked about a moment ago, where they consistently try the wrong answer over and over again. It's called perseverating. So recall this is what the Wisconsin card sorting task looks like. If they tried to sort it here, and they're supposed to be because previously the rule was to sort based on number, and now it's been switched to color, they'll keep trying to sort based on number and can't switch to color or try something else. So those are the attentional networks. These have important implications in our behavior, but also in things like attention deficit hyperactivity disorder. So this appears to be related to dopamine pathways from subcortical structures to the frontal lobe. So it's an imbalance between the alerting and executive control network. Treatment tends to be with methylphenidate or with D-amphetamine, which is Adderall. This tends to alleviate symptoms by increasing dopamine and norepinephrine. What happens is it allows those frontal networks to increase their activity and therefore increase their top-down control of other networks. So it allows to increase inhibition and increase overall control of the network. So one of the things that we're talking about here is executive control of these other systems. And attention deficit hyperactivity disorder has insufficient control and inhibition over those other systems. We know that there are some associations between gender and attention. In particular, males in general have larger right hemispheres, which tend to have some implications for this. We also know males are more than twice as likely to be diagnosed with attention deficit hyperactivity disorder. We also know that testosterone affects the dopamine pathways and has been shown to affect attention. And so it's entirely probable that there are some attentional differences between males and females. And we've started to see some of that in the behavioral data. And so what we think may be happening is males may be wired to be less focused on sustained tasks and more on sort of disruptive tasks. So things like instead of sort of that sort of tonic, phasic paying attention, are more actively involved and less able to ignore things around them. And that may have some survival benefits. It's certainly potentially possible. The last areas I want to talk about are the benefits of mindfulness training and attention. There's emerging evidence that integrative mind-body training, which is a form of meditation, can improve executive control over attention. Groups randomly assigned to 5 days of mindfulness training versus relaxation therapy have been shown to do so. So we're going to take a look here at some of the data from this very interesting study published in the National Proceedings of the National Academy of Sciences, where they actually put people into 5 days of mindfulness training versus just plain relaxation therapy, and showed some really remarkable results. This is important because it's potentially a way for people who have attention difficulties to have a non-pharmacological approach to treating their attention deficit disorder. So mindfulness training improved reaction times for attentional control. So in looking at the 3 different networks, alerting, orienting, and conflict, or executive control, we see that those participants in the experimental group are much more efficient when they're trying to resolve conflict in that flanker task. Mindfulness also improved mood as measured by the profile of mood states. So you can see this profile of mood states. This is in the group receiving integrative mind-body therapy or mind-body training. You can see the sort of before and after scores. So anger and hostility decreased, depression and dejection decreased, fatigue and inertia decreased, tension and anxiety decreased, and vigor and activity actually increased. So all positive things coming out of this integrated mind-body therapy or mind-body treatment. Interestingly, there was reductions in cortisol following stress induction. And so if you look at the baseline before stress, this is our salivary cortisol concentration, which again is our primary response to stress. So it's already lower in the experimental group. After mental stress, it's much lower. In fact, there's very little increase here. And after additional training, that cortisol is even lower compared to the control group. Finally, we see improvements in immune response. Finally, we see improvements in immune responses in response to stress. And what we see then is you can actually see after some additional training following the mental stress, we show pretty dramatic increases in immunoglobulin responses, which are part of this immune system response. So the integrated mind-body therapy improves attentional control and also has been shown to have other benefits. Finish up here with some discussion of some different drugs and how they affect attention. We'll talk about nicotine, a drug called modafinil, Adderall, and Ritalin, and then finally finish up with discussions of marijuana. So nicotine, we have shown in our lab that nicotine withdrawal has been associated with reductions in vigilance tasks. So some reductions because of that lack of nicotine has resulted in some attentional difficulties. Attention or mind wandering is a primary complaint of people who are trying to quit smoking. Nicotine has been shown to improve street performance but reduce orienting and the attentional network tasks. So there is some conflicting evidence about nicotine. It's certainly not something I would want to recommend somebody take to focus their attention, although people who smoke say it does help them focus. More likely it helps them not become unfocused because of the withdrawal. Modafinil is a newer drug that has been approved for treatment of narcolepsy, but people are getting prescriptions for it for adult attention deficit attention deficit disorder. Modafinil improves attentional control via the prefrontal networks, and so there is some evidence that it improves executive control. There's also some evidence that it improves fluid intelligence and other executive control tasks. It also has been shown to provide significant improvement in recovering methamphetamine users in their ability to control their attention. So it has some important uses. It's certainly something to consider for people who are trying to recover from things like methamphetamine use. Adderall and Ritalin are, of course, used for treatment of attention deficit and hyperactivity disorder. They increase dopamine and can increase attentional control. They can result, however, in things like hypervigilance. And then finally, marijuana. Chronic use in adolescence is associated with more errors in executive control. Oddly, there is some evidence for increased activation in prefrontal cortex for users, but they seem to be at a deficit because they had less efficient executive control. So if you look at these highlighted areas here, these are areas that are different for marijuana users versus non-users or chronic users in adolescence. And you can see much more effort going on in the prefrontal cortex, and we think that's because they have a less efficient attentional network. Somehow these slides got out of order. Apologies there. For Adderall and Ritalin, we see improved symptoms in ADHD by increasing executive control. And again, this is occurring primarily through dopamine and norepinephrine enhancing drugs. So all of these can have effects on attention. You can pause the video and take a look at some of these reviews about hemispatial neglect, which come from our previous lecture, some suggested reading for other areas for you to look at, and then finally some key terms and concepts. Thanks for your attention on attention.